This is just summary of the data with the ruxolitinib from the COMFORT-2 study. We know that there were two trials, the COMFORT-1 and COMFORT-2, that looked at use of ruxolitinib in patients with intermediate and high-risk myelofibrosis and compared to Hydrea or best available therapy. And in reality, if you look at this, majority of the patients will achieve a spleen response. Now, on the study, there was a requirement of 35% reduction by MRI volume for the spleen, which correlates typically to 50% decrease in the spleen size, and that was achieved probably in half of the patients. But majority of the patients will achieve some spleen reduction with ruxolitinib. And there is no doubt that it's a treatment that improves the functional status for the patients, their quality of life as well. Now, what we've learned that if patients have adverse mutations, that their response to ruxolitinib may not be as good. So if you think of patients that have somatic mutations such as ASXL1, EZH2, or DNMT3A1, those patients did not do as well in terms of durability of response. And that also matters by the number of mutations. However, if you look compared to Hydrea, the patients treated with ruxolitinib, even with high-risk mutations, tend to do better than those treated with Hydrea. However, it's not as durable response as obtained in those patients that don't have those adverse somatic mutations. And all over, when we think of the overall survival for patients on ruxolitinib, I think clearly that those patients will drive survival benefit. This is a pooled analysis from the COMFORT-1 and COMFORT-2, showing the median overall survival around 5 years for patients treated with ruxolitinib versus 3.8 years for those patients that were in the control arm, keeping in mind that there was a crossover in those studies. And I always discuss with patients that the goal of therapy is not improving overall survival. There is no evidence that the ruxolitinib treatment probably will reverse the natural history of the disease. However, those patients' symptoms improve, their spleen is reduced, their functional status is improved, their performance is improved, and thus they drive survival advantage. So if I have an intermediate or high-risk patient that is symptomatic with splenomegaly and constitutional symptoms, I do think that they drive survival advantage from the treatment. And this is looking at, when we look at the responses and the survival, correlating the spleen response with survival, we know that there is correlation between a spleen response and survival. So when we look at the spleen response at 6 months and overall survival, there is correlation with that, and correlation between those patients that had a stable response or a unstable response even compared to non-responders. So there is correlation between spleen volume reduction and overall survival for those patients. Now, one thing to keep in mind, it's important to titrate the dose early for those patients. And in many occasions, we shy of using the appropriate doses of ruxolitinib, sometimes worried about the myelosuppression, and we start on a lower dose. And in cases of borderline cytopenia, maybe that's acceptable. However, I think the message is that if we are, if the patients are tolerating the treatment, one should escalate quickly. You definitely do observe a dose-dependent spleen response. So the higher the dose of the Jakafi, the higher the spleen reduction or a response is. The symptom improvement typically starts at around the dose of 10 milligram BID. So what I do, if patients' counts are appropriate, I start with the full dose. If the counts are borderline and I started at a lower dose, within the first month or two, based on their blood counts, I'll try to escalate the dose to the maximum tolerated by the patient. Now, obviously, the major concern is the myelosuppression, where almost half of the patients will develop some anemia on treatment. Typically, the hemoglobin will drop between 1 to 2 grams. Around week 8 is where the nadir is. Thrombocytopenia cannot be observed as well, but less often we will be dealing with neutropenia in those patients. Now, there have been studies trying to look at patients with platelets between 50 to 100. The original COMFORT-1, COMFORT-2 study required platelets above 100. Subsequently, there were patients that had thrombocytopenia in the range of 50 to 100. That use of ruxolitinib was tested in those patients, and it was determined that probably a 10 milligram starting dose is safe in those patients with same expected thrombocytopenia and anemia that we observe in the in patients treated when their platelets were above 100. Sometimes we would start at a 5 milligram BID dose in this group and escalate up to the 10 BID. And if they are tolerating that, we could consider even further escalation in those patients. And when you look at the spleen response and the symptom improvement in those patients, the magnitude of benefit driven, if one would go with this dose escalation policy, is similar to what we expect or see in patients with platelets above 100.